All right, we're going to go ahead and get started. Thank you guys all for attending today's session on brain injury for landlords and service providers. Today we have Carly Andries. Did I say it right?
Yeah, you did. Yeah.
With the North Dakota Brain Injury Network presenting. Again, just a quick reminder, please leave your microphones and your videos off during today's presentation. So I will turn it over to Carly.
All right, thank you, Kylie. Hi, everybody. Welcome. Thank you for coming to this training that obviously I think is very important because people with brain injuries are near and dear to our hearts. I am the Outreach and Education Coordinator for the North Dakota Brain Injury Network. If you are not familiar with us, we are the central source of brain injury information, education, support, etc. for the state of North Dakota. Our funding is through the Department of Human Services, so there is never a fee for any of our services that we offer, so don't worry about that being a barrier. We are located in the med school on UND's campus in Grand Forks, but we do serve the whole state. There are 3 of us on staff, myself and Rebecca Quinn is our director, and then we have Nikki Livdalen, who lives in Towner, North Dakota, on staff as well as our resource facilitator. You'll see ndbin.org is our website, and it's a great one. There's a resource directory on there that's searchable by either by ailment, or whatever you're looking for, occupational therapy, physical therapy, etc., or you can search by where you live within North Dakota and what's close to you, because we know sometimes for those rural people that can be a barrier needing to travel. We do have that 1-800 number. Nikki answers that. That's a live person and answers at least from 8 to 5. She answers that. So any calls we can field that way. And then also you can email that info@ndbin.org, or I can put my email in the chat as well. So let's get started and talk about brain injury. What is a brain injury? So a brain injury is a little confusing because it's kind of an umbrella term. Acquired brain injury, or an ABI, is all brain injuries, and that's any damage to the brain occurring after birth but prior to degenerative dementias. So a lot of times we get questions such as like fetal alcohol syndrome, and that is technically not a brain injury, although a lot of the characteristics match that individual with a brain injury, but technically it's not, because it would have occurred before birth, so anything after birth. But then after that, we have 2 categories. We have traumatic brain injuries, or TBIs, which occur from an external force. So those are mostly our sports concussions, motor vehicle accidents, domestic violence. There's a lot of reasons, bar fights, basketball, or I said sports injuries, I guess, but lots of injury related things. And then we have the other side of the spectrum, which is more of those internal forces. So things such as strokes or tumors. COVID has been, people are seeing some effects of COVID, just being on those that have to be on ventilators for a long time. Our bodies aren't meant to do that. Infectious diseases, chemical or substance exposure. So a lot of times drug overdoses, or anytime the brain is deprived of oxygen, there can be an effect on that. So for TBIs, the leading causes are falls. Unintentional fall, or falls, slipping and falling on the ice is the #1 reason in North Dakota. So we always really try to promote salting your sidewalks, walking like a penguin, using those spikes on the bottom of your shoes. A lot of our clients woke up in the emergency room and were just walking to their car or walking their dog in the wintertime. So be very, very careful. Then we go around unknown or other. Motor vehicle accidents, struck by or against, and assaults kind of make up the leading causes of TBI. So why is this important? Because a lot of that results in a long-term disability. A brain injury is a chronic condition. There is no cure for a brain injury. A lot of it is symptom management. But it's estimated that about 15 to 20% of brain injuries are going to have those long-term effects. So in North Dakota, we have roughly around 12,844 people living with a long-term disability as a result of a traumatic brain injury. So that's not even including strokes and those kinds of things. So brain injury is a tough one for a lot of people because we can't see it. Well, as clients, you would probably never know that something happened to them, and that can be really hard and scary for the caregivers of these individuals as well, because they act a lot different after their injury. Sometimes you can look for scars and things, but usually those aren't even able to be seen from a brain injury. A lot of brain injuries go unreported, and those are mostly our domestic violence cases. People are afraid to go in and seek treatment, or if they do, it's much later. So there is still potential for rehab, but we would prefer that people come in the sooner the better. And then minor concussions technically are a brain injury, and a lot of people don't realize that, and especially multiple concussions in a short period of time are going to create a lot of problems in our brain, because our brain does everything for us. But once we have one concussion, our odds of getting another one are 3 times higher. And then once we have a second one, our odds are 8 times higher. And it just keeps going and going from there. Basically, you've cracked that foundation. And once you crack it, it's so much easier to happen again. So it's really important when someone does sustain a concussion that they take that time to heal. A typical concussion should heal itself within 4 to 6 weeks. If that doesn't happen, that's when you call us and we can try to help set you up with the correct service providers. So what happens after an injury as far as more than a concussion? These are our possible consequences, and you'll notice that the big orange one, fatigue and lack of awareness, is the biggest, because those are the kind of the most important and the ones that weigh the heaviest on the individual themselves. Fatigue for someone with a brain injury is difficult because they have a mental fatigue and a physical fatigue. And that mental fatigue really takes over and weighs on them. Brain breaks are something we often highly recommend for even our adults. You know, we're entitled to our 2 15-minute breaks and a 30-minute lunch, but we usually would probably double that for someone with a brain injury, and not necessarily a nap, but just time to shut your eyes and relax and just give your brain time to transition to the next thing, and rest. Physical changes come next. Those we don't hear as many complaints about because those are usually resolved pretty quickly. And honestly, a lot of people, I think, prefer almost to have those physical changes, because then they aren't the invisible people, like that people know then that they have an injury and that sort of thing. Cognitive changes are very hard for our survivors as well. But your IQ doesn't change with a brain injury. It's not a learning barrier, it's a processing speed. There's delays with processing speed with a brain injury. We don't always know why, but there's glitches. And so sometimes we need to make accommodations for that person to learn better, but typically they still can learn all of the same information as everybody else, but they just need it presented in a different format. And then the last one is the emotional and behavioral changes. And that's probably the hardest part for both the survivor and their caregivers, because again, they look the same, but they act differently, and they can become very emotional. And they have a lot of emotional dysregulation, lots of ups and downs, and crying for no reason and things like that. So here it gets into some more of a list of some of the physical consequences. And so our brain controls everything. An individual can have motor difficulties, they can have trouble moving their arms and legs and so forth. This can be generalized weakness, or it can be very specific, affecting only one side of the body, depending on where their injury happens. In most cases of TBI, motor difficulties tend to improve fairly quickly. And by 1 year post-injury, usually people are walking without difficulty. Physical consequences that improve during the first year may lead people to think that they're recovered, but other consequences may often show us that they are not completely recovered yet. There's a lot of sensory limitations for someone with a TBI. Vision, hearing, touch, smell, all of those can be affected. A lot of our survivors will talk about that, like they like spicy food now because they can taste it. They can't taste really bland things anymore. Or vision. A lot of people have field cuts. So they'll be looking, their eyes are working, but they'll have like just a blank black space in the middle of where their eyes are looking, kind of, or field cuts in the corners, or just depends on where. And that can be very, very frustrating for people. Dizziness is a very common side effect of TBI, and tinnitus. So it's ringing in their ears that just basically doesn't stop, and they're constantly having a ringing in their ears. So you can imagine going throughout your day with a constant ringing can be pretty annoying. And headaches. Headaches are probably the most common complaint after fatigue, and can really weigh on an individual, and they can persist for weeks and months out after an injury. So some other just general things as far as like a landlord and a service providers. A lot of times our individuals struggle with just general upkeep of their home, and that can be part of their physical consequences. And so they might need some support with that, and that's where those service providers come in. I don't think all of our survivors really need like someone all day, every day. Some might, but others might need someone just checking in on them a couple hours a day or a couple hours a week. Some of our survivors struggle. We have one girl that I thought of when I was asked to do this presentation. She struggles with even those concepts of like plunging your toilet, how to go about doing that, and walking her through that, and showing her those kinds of things step by step. Breaking tasks down can really help someone with a brain injury work through problems. I'm going to go on now to cognitive consequences. So after physical, or in addition to physical problems after a TBI, a person can also experience cognitive problems. In fact, for the most cases in severe TBI, there is a greater impact from the cognitive problems from the physical consequences. The cognitive problems tend to have a generalized impact. Many areas are often affected within a person's thinking skills. So they can include problems with arousal or an individual's alertness. So oftentimes, to be perfectly honest, they look like the lazy person, our survivors do, but it's an arousal thing. If we're not aroused, we can't do anything else, and our brain is where that arousal gets stimulated. Being able to have input and output channels are extremely important, and another basic foundation skill. And if someone is unable to sense like their world, or unable to engage in motor abilities, they cannot do so much cognitively. Attention and concentration involves selecting what is important and being able to shift your attention when necessary, and then being able to maintain it. So a lot of times with our survivors, I would say they almost have a co-occurring, like their primary symptom is their brain injury, but then a co-occurring would be ADHD. They have a lot of those symptoms of ADHD. And so just paying attention to something and maintaining it can be really hard for them. Language skills, that's referring to the ability to understand what is said to you in verbal or written form, as well as being able to express yourself verbally or in writing. So in most cases of TBI, these basic skills do stay intact. But the problem is more likely to be with pragmatic skills. So for example, being able to use language in a functional manner to explain concepts is going to be hard, to give instructions and so forth. So their expressive language is hard. The problem is often at a higher level than just basic reception and expression of language. We had that same individual I was referring to that had trouble plunging the toilet. During COVID, her landlord changed the way they were accepting rent from handwritten checks to virtual payments. That blew her mind. That was really difficult for her to wrap her head around and for her to understand and figure out. So we did help her with that, and we walked her through that, and that is very much within our realm and our wheelhouse, and we are more than happy to do that. So if something like that happens and someone's struggling picking up a new concept, please reach out. We take referrals in the form of self-referral, so someone can just call us and tell us, hey, I have an issue, or you as a service provider can make a referral as well. And we have that referral form on our website, and if I have time at the end, I can show you where to find that. But but change is very hard to. We stress on our end to the survivor routine, because we want them to be in a routine all the time and know what's coming next for their brain. That really sets up their brain for success if it's got, it knows what to expect. And so when we throw a curveball at them and we change the way we do things, that can really impact them. So please let us know if that's something, if there's ever things like that come up that we can help support. So emotional behavioral consequences, we kind of refer to these as the 3 I's: impulsivity, irritability, and impatience. Very, very impulsive. Waiting is really hard. We work a lot on teaching what to do while we're waiting, and how to be appropriate, those social skills. If you ever want to know how you look someday, ask someone with a brain injury and they'll give you a very honest answer if that's a nice haircut or not, or a nice new top. They're very, very honest people. But then there's, at the same time, they have a lot of them, either they'll have times where there's like a reduced self-esteem and very low and depressed and blue, but then other times where there's kind of an overinflated sense of self. And there's kind of those highs and lows. There's definitely a frustration piece for our survivors. A lot of them remember themselves before, and they, they used to do that fine. I paid my rent just fine before my injury. And now after, I struggle. And so that's a really hard thing to come to terms with and to start to accept. So we work a lot on that piece too, the acceptance and the awareness of our injury. We often say, don't be a jellyfish with someone with a brain injury, though, too. We have to be very direct and very firm. And having a big, long, drawn out lecture discussion with someone with a brain injury isn't really going to get you very far. You just probably want to say, like, your behavior is inappropriate, whatever it might be. You need to stop. Those kinds of things. And you might have to say that more than once, but that is my info on emotional behavioral. So
we do have a question.
Oh, sure. Go ahead.
Do people with a brain injury, depending on the severity, need special accommodations?
And yes, depending on, and I guess if you want to be more specific about what kind of accommodations you're talking about, but yes. You want to give me an example, or what do you mean by accommodations? But yes, like in the school setting, for sure, we almost always recommend accommodations. But if you're talking in the home, can you be more specific?
Yeah, when it comes to housing.
Yeah. Are you talking grab bars and physical things like that, accommodations? Yes, I would say so. And I would highly recommend, if there's someone struggling physically navigating the building or wherever they're living, ND Assistive is amazing, and they can help a lot. I really like that they let you try before you buy. So much of this equipment is very expensive for an individual to purchase. And so, and they have a smart home all set up. There are so many capabilities now, even with like an Alexa thing, which is not very expensive, but you can have Alexa do a lot of things for you. So as long as they're able to verbally command, Alexa, turn on the TV, Alexa, shut off the water, they can hook it up to so many different things nowadays. And yeah, it just really depends on the person and how impacted they were by their injury, I guess. If that makes sense.
Yep, thank you.
Yep. All right, so co-occurring. All right, so unfortunately, it's usually not just a brain injury for these individuals. So more than 50% who have a brain injury also have co-occurring behavioral health conditions. Substance abuse and brain injury go kind of hand in hand almost, and especially if that individual was a user of substances prior to their injury, they're going to want to be very careful following, because that impulsivity and their inhibitions are lowered. It's much easier to say yes to things. There was a very interesting study done at Ohio State University. Dr. John Corrigan, it sounds horrible, but they took rats and they damaged their brains. And the female rats became 100% addicted to alcohol within a very, very short, I want to say 48 hours within starting the experiment. And so much so that the students, the college students that were selected to work on this experiment had to go in at night. They had to reformat their key fobs to go in at night and refill these water bottles with vodka for the female rats. So especially with females, so Dr. Corgan likes to talk about, when he presents, he'll say, if we don't warn people with a brain injury about their risk of substance abuse, then it's like not warning Little Red Riding Hood about the big bad wolf. We need to tell people that this is a potential problem and to try to avoid alcohol, drugs, anything like that. Depression and anxiety, mania, psychosis, personality disorders, all of those as well are definitely very serious and come along oftentimes with a brain injury. As I've said, our brains control everything. And so when they get jumbled up, there's just a lot of negative outcomes that can happen, and a lot of hard time with the acceptance piece of it, and a lot of anxiety as far as like what's coming next. And I don't know how I'm going to feel today, if I'm going to have a huge headache, or if I'm going to start crying when I should be laughing, those kinds of things. So that is a struggle for a lot of our survivors and, again, their family members. But there is a lot of options out there for counseling, therapy, mindfulness, doing a lot of different symptom management things that we can help with too. So I think this slide is helpful. It's a lot of information. I know this is a long acronym, but I think it's a really good way to help remember to accommodate for an injury. So we can reduce the amount of information we give. Kind of like I said before, don't lecture at someone with a brain injury. Give them just clear, simple direction. You cannot keep your child's toys all over the lawn. Please pick them up and put them back in the shed every night, or whatever it is. One instruction at a time. Multi-steps are going to be very hard because they're going to forget what you said for the second step. So have them do the first step, then you can do the next step. Or if you can have some kind of visual where they can check it off when they're done. Written and verbal are good whenever possible, if you can provide both for them. So verbal feedback, we take in most of the information we learn through our eyes, through sight, like 88%. And so we really want people, if people are going to understand a lot better what you're saying to them if it's written down too. We're in a very verbal world, and I'm sure in your guys' field too, it's very verbal, a lot of verbal direction. But anytime you can have something in writing for that individual to review or look at later, even is very helpful. I don't have a specific like landlord example, but I think if the doctor's office is constantly giving you verbal feedback, verbal information, but then you usually get that printout when you're done at the doctor that kind of explains your summary of your visit, and those are very helpful for that person to review because they might not remember every detail that was talked about later. Breaks are helpful, like I've talked about brain breaks. Fatigue is such a problem for our people that a break whenever possible. Like I said, the often is better. Routines are very helpful. Let's say you have to have weekly meetings or monthly meetings, maybe with this individual renting from you or however often. I would highly recommend keeping that meeting on the same day of the week and the same time. And if that individual misses or you have to cancel, don't reschedule, just see them next week at that same time like you usually do, or that next month, or whenever it is that you usually do. We've learned that through our probation officers and our work with the criminal justice system. They have found that it's better just to cancel and move along because you're throwing off their world if you give them, if you normally see them Wednesdays at 3 and you move it to Thursday at 5, they're probably not going to make it. So just save everybody some time and just try again next week. Ask a person for paraphrase and repeating. And that's good because it activates different parts of our brain. It's basically like an I teach, you teach. So when we're learning something, that's activating one part of our brain. When we're teaching something, it's activating another. So if you're explaining directions to them, you might want to say back, can you tell me that in your own words? Or what did I just, can you repeat that? What did I just say? Because that's really going to help gauge their understanding of what you did just say. Taking time, going slowly. Again, processing speed, there's a glitch somewhere in there for people with a brain injury, and they need more time. They often know the answer, and they just need more time to gather that, form their thoughts inside their head. So go slowly. Oftentimes it's almost a little awkward, that wait time with them. I would recommend a full like 30 seconds to a minute. I usually count in my head, like 1 banana, 2 banana in my head while I'm waiting for them to respond. And it's often past 30 by the time they generate a response. So really trying to just take that time. I think in our society, we want to fill silence and just kind of keep talking. But if you just kind of zip it and let them think for a minute, they usually can come up with a response. And then simple and organized information is going to be the best way of presenting that information. Like I said, simple language too. That's one thing when we're going to write any information down, we really try to make it as reader friendly. Readability, we look at about a 6th grade reading level. I wouldn't go further than that. And there is a way, like when you're doing a Word doc, you can check the readability level of it to see if how high it is and if the words you're using are a little too big, things like that. So again, I already mentioned this, but don't be a jellyfish. We want to be concrete and consistent, and we don't want to schmooze with people with a brain injury, okay? It sounds harsh and it might come across harsh, but I honestly, I think if your tone of voice is appropriate, I don't think they're going to take it that way. I think they're going to appreciate your honesty, and it's just going to help them understand what you're saying more. Brain injuries, they work best with an antecedent-based intervention. So by antecedent, I mean what happened before their behavior. So if the individual I work with can't handle loud restaurants, we're not going to go to a loud restaurant. We're going to go somewhere quiet. We're just going to completely remove that antecedent and not even put them in that position. But they're not a punishment-based population. They respond not well at all to negative reinforcement. So anytime you see positive behavior or positive things happening, oh, I loved how you mowed your lawn this week, it looks great, or something like that. You want to notice it and encourage it, or like, look at your apartment, how clean it is today, things like that. Okay. Oh, do you have a question?
Yep, there's a question. What reading level did you recommend?
Sixth grade. I wouldn't go higher than 6th. Most newspapers are written at about an 8th grade reading level, if that gives you kind of a good idea. But you can imagine in the newspaper is a little hard because they do have some vocab and stuff that's going to be higher than that. But I wouldn't go higher than 6th if you can. Stick around 6th grade words and level. Okay. So I kind of mentioned this before, but I think it's also important to talk about because I would assume this might be some of the population that you're seeing, but the criminal justice system and brain injury is very unproportionately identified within that system. You can see these numbers here are pretty shocking, they're very high. And so a lot of these individuals too, their injury occurred before they were incarcerated. So we actually just received a new grant where we're going to be working on screening this population. So I don't know if you're familiar with the terms Free Through Recovery or Community Connects, but we are going to start screening all individuals that come through those programs. So those are kind of like post-incarceration programs and treatment programs and things. And so the care coordinators that work in those programs are going to screen individuals that come out or that are in those programs. And if they screen positive for brain injury, then they are referred on to us and can decide whether or not they want to utilize our resources. But we basically want to try to give these individuals tools on how to prevent them from ending up back in jail. A lot of times, a lot of those symptoms that I mentioned before, and those emotional problems, make our individuals kind of snap, or if you can imagine a constant ringing in your ear and foggy eyes and a headache and just all those different things that you think about on top of having to get your job done or whatever it might be, it's just gonna be a lot for people. And so giving people tools like symptom management tools, mindfulness things. There's just a lot of tricks we can try to implement with them. So something to think about, that if they do have a history of involvement with within the criminal justice system, there's a strong likelihood that they have a history of TBI as well. And then again, if they don't have a diagnosis and they could use some support, that's where we can step in and offer that screening tool as well. And we also have a symptom inventory that we have them complete. And if they screen positive, and whatever areas they come out high on. So it goes through a whole gamut of basically executive functioning skills. So memory, attention, emotional dysregulation, anger, fatigue. It goes through all these different areas, and what they score high on, then we provide them with tip sheets, but we also would provide you as the professional that knows this person and is working with this individual some tips as well. So there's two sheets. So there's an anger for clients and an anger for professionals. And so you know what to look for. And then on the back of them, they have accommodations as well, of good suggestions on how to help that individual through that piece. Homelessness is also a big area where we see a lot of our survivors. Again, most of them prior to losing their home, as you can see, that 87%. So again, this is a population that is very highly overrepresented within the homeless population. And so we again want to try to give them those tools and things like staying organized and staying on top of our bills, and keeping our home and our mail. We have even like a trick, touch it once is something my boss tells our clients all the time. When you get the mail, touch it once, put it in a spot where you're going to remember where it's going to go, because if you have 5 different spots where you keep all of your mail, your brain doesn't remember to go back to that spot. But if you have a designated mail spot, you go back to that spot every time, you're going to probably be more likely to remember to pay bills and remember to keep up on things and stuff like that. So so that's just an example there. Again, I know I talked a lot already about substance abuse, but it is such a huge prevalence within this population. And many times people are going to develop a problem after their first injury. So yeah, we have a lot of people that are accessing substance abuse services, and they have a history of TBI as well as inpatient services. Suicide risk is also something that's prevalent in the brain injury world. As you can see, this study found even years later, it's still an issue. If you're familiar with suicide at all, and there's kind of a cycle often that the individuals left behind will say that they probably did notice in hindsight, giving the way of materials and things like that, and planning. And with a brain injury, being that our skills are kind of goofed up, we don't always, the individual with a brain injury doesn't usually go through through those steps in the way that someone without a brain injury would. And so they often just jump to the final act. And so that's the really hard part about suicide and brain injuries. We don't often see it like we can sometimes and intervene with others. But I would say, chronic states of depression, fatigue, those kinds of things, they need some help. They need to talk to someone, and we can help set them up with that. So as I said, there's really no cure for brain injury. There are many treatment options available though, and that's our job, is to help people navigate through that process. And another thing that NDBIN offers that I always like to mention to people is that we can do like personalized trainings. So let's say you have several people that have a brain injury, and you want more, feedback on how to work with them, or tips and tricks. And oftentimes we'll have agencies reach out, and no offense to our clients, I think I could say this to them lovingly and they would still appreciate me, but these are kind of the people that drive you a little bit nuts sometimes, to be perfectly honest. And so we will have agencies make us a list. And, why did they always do this? Why do they always do that? And we can try to help you give some reasoning. We're not excusing any behavior. We're trying to explain it. We always say brain injury is an explanation. It's not an excuse. We're not excusing their behavior. That we think that behavior has the ability to be changed. But it's important that they get the proper supports in navigating that process. And I was going to show you guys just a couple things on our website since I still have some time, but that's kind of the end of my formal slides. But I'm going to stop share of this and start share of our website, just in case you haven't had a chance to check it out ever. One sec here. Do you have a question?
Yeah, we've had a couple people ask if you could speak a little louder.
Oh, I'm sorry.
Thank you.
Yes. Is that better? Trying to be loud. Might have backed away too. Okay, so here's what our homepage looks like. Are you seeing what I'm seeing? My homepage. So up here in the right is where client referral is. So I was talking about that referral form. So here's where it is a typable, fillable PDF. You can type in it or you can print it and scan it, and there's directions on there on where, but you can even see the organization making the referral. That could be you, or we take personal self-referrals as well. Just to talk through a little bit the services that we offer, so community resources. So that's basically giving those information on what we think you would probably be best utilizing within your community. Brain injury information, we just have, like I talked about, flyers, and we have a guide, and we have all kinds of different printed things on brain injury, and we know good other spots where you can find things if needed. We do facilitate all the support groups within North Dakota, maybe not ourselves personally, but we help the facilitator plan if they need it, and work closely with that, and we help advertise and those kinds of things. So we usually know what the scoop is, and when those places meet, if there's someone interested in a support groups make a world of difference. Our survivors often will say they wish they had found their people earlier in their recovery. So they wish they had found more survivors like them. It's very, very comforting to someone with a brain injury to meet other people that are experiencing the same things they are, and can talk about that and work through that together, because oftentimes they can't really talk about it with family or friends because they really can't relate. They don't know what they're going through. Survivor Connections is basically, if you're a newer survivor, we pair you up with a veteran survivor, and then our resource facilitator, Nikki, the three of you are on a three-way call once a month for about 3 months. And then depending on if you need more support after that or still have questions after that, we can work something else out after, but we kind of like to initially hold your hand a little more and help you through the process a little bit better, because it is so confusing and you're given a huge pile of stuff from the doctor's office and you just on discharge and things, and you just don't always know what to do. And case consultation is the other piece I talked about, and that's where you can contact us for kind of that technical assistance piece, and we'll individualize it for your area, just like this presentation was basically individualized for landlords, and service providers, those kinds of things.
We have a question.
Yes.
I might have missed this, but what are all of the causes of brain injury besides being physically hurt?
Okay, so causes, yes. So we have brain injury falls into those two categories. So we have acquired brain injuries. Those are things like strokes, tumors, drug overdoses, near drownings, anything really where oxygen was taken away from the brain. Then we have traumatic brain injuries where it's an external force. So sports injuries, domestic violence, motor vehicle accidents, but falls are the number one. That especially in North Dakota, the weather, slipping and falling on the ice is the biggest reason we see in North Dakota. So we have a huge range of how a brain injury happens. Abusive head trauma, so shaken baby syndrome. We're kind of trying to change the terminology there, because that baby's going to grow up into an adult, and so we try to say abusive head trauma now, but that's something else we see quite a bit of. Yeah, I think I covered all of them there.
Do the fatigue, decreased stamina, and some of the other issues get better in time or not?
Not always, unfortunately. I wish I could tell all of our people that. But no, not always. It can actually sometimes even get worse. It's really hard, and it especially depending on if the aging process is coming into effect. Because let's say you were in your 20s and you had a few concussions playing football or something for college, and now you're nearing your 60s or 70s. Your brain probably for the past 40 years has been working really hard to compensate for those old injuries. But now once the aging process starts, it's really hard for our brain to keep compensating. And so it kind of definitely loosens up, and it doesn't do as great of a job as it was before. So we'll get a lot of those cases, or not a lot. We see that quite a bit where people have an older injury and then they start to see more effects as they're aging. So I'd say if it's an older individual, their stamina probably will decrease. And younger individuals, I'd say it's more of an initiation problem. Like I talked about, the lazy, like they're just lazy. And that's a good thing to try to think about, is if they're a can't or a won't, which in like the education world, teachers understand the can'ts are the kids that literally they cannot do the work. It is too hard for them. The won'ts are the refusals and the ones that just refuse to do the work. And so we can think about that in the adult world too, or in your guys' worlds too. Is it someone just kind of being negative and refusing, or is what we're doing, if what we're asking them too hard, or are we not giving them kind of those accommodations to make sure that what we're asking is even within their wheelhouse, if they're even able to perform that task? That's kind of something to think about too.
Okay. Why are TBIs so underreported by the medical field?
Well, funny you should ask. A lot of it's because of depending on how what I wouldn't say it's not reported by the medical field or to the medical field, do you mean? A lot of people don't go in, they might not see it as a big deal. We live, especially in North Dakota, and us Midwesters, we're strong and we don't need any help and we don't need to go to the doctor. We see that a lot. I met an individual at group one time that was driving semi when he had a stroke, and he continued to drive his semi for like 2 more hours and didn't want to admit that anything was going wrong. But as his arms getting numb and his vision's going and those kinds of things, that's very scary, but it is hard to admit and accept that we need help. And another tricky part with brain injury is you can't really see it on a scan. You can see skull fractures and like really, really significant injuries, but a concussion is cellular damage. So you're not going to see it on a CT or an MRI or anything like that. And that's a really hard thing for our survivors to wrap their head around, and even their family members. They want to see it, but my scan came out fine. I'll say my CT was fine. Right. And that's what we hear a lot is, yeah. So that's another part probably why like the underreporting, or people maybe not really understanding that they do have a brain injury. And that, like I said, typical concussion should heal itself within 4 to 6 weeks. If it doesn't, then we need to work with maybe a speech pathologist or an OT or a PT on building your skills back up. And there is that idea of neuroplasticity where we can get back, not exactly, I'd say, to where we were pre-injury, but we can make very good gains, and you would be surprised to see how far people come. We just had a speaker last week, actually, a survivor that his injury happened in like the 70s. And when he was first referred to speech pathology, she recorded him his first few sessions. And when he was done, after a year working with her, she played back the first day and she said, I want you to listen to this. And he listened and he was like, this is like a little kid. This isn't me, he thought, he was just blown away. It just did not sound like him, and he couldn't believe that he had come so far. So there is like that concept of getting better, but probably not to the level that you were before. And that's, again, that acceptance piece comes into play.
Are some forms of dementia considered brain injuries?
My boss is so much better at answering this one than I am, but we do get that one a lot. So dementia kind of falls into almost two categories. There's progressive dementia, degenerative dementia. So that's like an Alzheimer's where it gets worse and worse and worse. But true, just the definition of dementia is memory loss. So yes, like literally everyone with a brain injury has dementia, but people get a little excited because you got to think about the term dementia and what it means. And it's memory loss. It's not that it's degenerative. It's not that it's getting worse and worse. Like I said, brain injury is chronic. So it's not acute. Well, there's an acute phase of it, but then it continues to, it's something that that individual is going to struggle with on and off for the rest of their life, basically.
And then there's just a comment. People have been in comas after being in a car accident where they hit their head and they do not receive any info about TBIs. They may get PT, but they don't receive any info about their TBI.
Mm-hmm. And yeah, that's awful that that's happening. And we're trying, the medical world is a hard one to get into and a hard one to tap into and to have people without all the well, I have some letters behind my name, but not the really big letters like doctor and MD and all that. And it's really hard for us to break that barrier and go in and say, like, you need to give these people more information. We are trying, we're really trying to do that. Sanford has really embraced us in our program, I would say. Like Sanford Fargo, my understanding is on discharge. If you were diagnosed at the time with a brain injury, you should be given like a whole kit from us with our guide and all of our information in it. I know Sanford isn't everywhere in North Dakota, but we have made gains with them. We do need to do a better job of getting into the rural areas. I will admit that. The trainings that we have provided and offered, we are getting more and more. So we have a, behind my name, if you didn't notice, excuse me, back at the first few slides, I'm a master's, but then I have a CBIS, so Certified Brain Injury Specialist. And so basically, that's a very rigorous training that we offer. And then it's the Brain Injury Association of America that is certifying you to be a CBIS. And so to maintain your CBIS, you have to take 10 CEUs in the field of brain injury every year. And so we're really working on that and promoting our CBISs. And since I've been with IndieBin, we're coming up on 4 years. And when I started, we had 4 CBISs in North Dakota. We're now up to 72, and we're very proud of that. We have 30 coming to training on Monday, actually, throughout the state. And so we're trying really hard to tap into everyone. But that buy-in piece from the medical world, or just getting them to disperse our information is difficult at times. I'm going to keep showing you guys some stuff if that's okay. I wanted to show you one other area on our website. Am I still screen sharing?
Yep.
All right. So one thing, and some of you that might be service providers might have already had to take these, but if you go under our events and training and you drop down to training opportunities, we have these online brain injury courses. We have 5 of them. They're listed right here. And here's Rebecca kind of explaining them, but there's an introduction to brain injury, a cognitive and behavioral consequences, primary care, pediatric, and substance. If you're a North Dakota resident, you do not have to worry about this cost. I can give you the promo code and you can take these for free. But if you are a service provider, so our QSPs and service providers that work for our QSP agencies and they work with someone with a brain injury, they have to take our Force 2, the Intro to Brain Injury and the Cognitive and Behavioral Consequences. And I'm obviously biased, but I do think they're somewhat helpful. They're pretty basic. They're video module format. So it's videos, then you take a quiz after, and then there's a final at the very, very end. But these are the CEUs that we do offer for these courses. So if you do need CEUs anyways for your job at all. But yeah, the first 2 I would highly recommend. These are all 1.5 CEUs with the exception of substance use and TBI. That one is 2.5 CEUs and it's longer. And that one to me is more geared for like your addiction counselors and people like that. There is a flyer here too, if you wanted to print that at all and post it like in a break room or anything and promote that to any staff. We offer free decks of playing cards. If you haven't got your free deck yet, hop on and get it. You just fill out this little form here and you'll receive a deck of cards in the mail. They are traditional playing cards, but then there's a fact about brain injury on each card. And it's kind of a fun way to work on rehab, because playing games and doing cards is fun rehab. And then it's also good just to learn the facts and learn different things about brain injury. And a lot of times our caregivers really like these cards because, our individuals like to give them to their caregivers, I should say, to help explain because of that whole invisibility piece. And they really, a lot of like older gentlemen in the North Dakota realm, oh, you're fine, that was years ago, your injury's done, they'll tell their kids that and things, and that's not the case. Like I said, it's a chronic condition, so they're going to struggle on and off for a long time. So the cards help with that. And then last thing, that resource directory is here. This is what I was talking about when I talked about that resource directory. So you can search, you can click on your area and where you live, and it'll bring different therapists and things we would recommend up, or you can go by type of service. So music therapy, you can click on that if you want to look into where that is in North Dakota. Places that provide telehealth services, that's becoming very popular with the COVID world. And to be honest, we promoted it way before COVID because it's we serve the whole state, and North Dakota is very rural, and it can be a big barrier for our people like up in the Crosby area to get down to Fargo for a neuropsych exam or something like that. So or whatever it might be, they can do it via telehealth. So just wanted to show you guys some of that. Any other questions or anything else that I can answer?
I'll give it a minute here in case somebody's typing.
Yeah, no, that's fine. That's fine. I'm all yours. But yeah, I think you service providers, I don't know if this, I tried to gear it to you, but I know a lot of you have to take those courses, but for landlords, especially if you're suspectant of one and you want us to do a screening, you want some of our business cards, or we have magnets with our phone numbers on them, things, if just casually asking. I know it can probably be awkward too if someone isn't disclosing their injury, but if you're seeing some of those symptoms that I talked about, or some of those behaviors I mentioned, just, have you ever bumped your head significantly or something like to that effect, or anyone ever told you you have a brain injury and I saw this presentation, and you can make us the bad guy, call this girl Carly and see what she thinks. And our screening is nice. A lot of people ask that, how do you do a screening? It's not a scan. Like I said, it's not going to show up on a scan, so it's not a scan or anything like that. It's questions. It's an interview basically, and it's asking about your history of hitting your head or strokes, aneurysms, those kind of things. And I like it because choking, strangulation, that's another reason why we see brain injury too from domestic violence. That asks about that. But a lot of times people don't think of certain things in the same terms that like the medical world does. So, loss of consciousness is what they tend to use in the medical world. Well, that's kind of a big term. So knocked out. Have you ever been knocked out? If I were to ask the same individual, have you ever lost consciousness? Oh no, I've been fine. Have you ever been knocked out? Oh yeah, a couple times, so does not show up medically. So Vicki, yeah, it really doesn't show up on scans unless it's significant enough to cause something like a skull fracture or things like that. It's not going to show up on a CT. Or a functional MRI, you might see some, but they're not going to show up on a scan. So usually it's diagnosed through something like a neuropsych exam. So when we give our screening, we give the screening, and if they screen positive, so basically it's 4 different questions in 4 different areas about their history, and if they have enough answers. And it also depends on age too, your age of injury, because actually it's kind of a misnomer. People, it's a misconception that it's better when it's younger, and it's not. A lot of people grow into their injury. Time reveals rather than heals is something we say too. So oftentimes if an injury happened, at 2 or 3 years old, again, kind of like that same example of the aging process where their brain has been compensating and has been keeping up with peers and keeping up, and then the workload gets really hard and hormones come into play and all these things, and then we see a big dip, and their effects of their injury kind of come forth at that time. But yeah, no, you're not going to see majority of brain injuries on a scan of any kind. So yeah, typically if they screen positive, then we recommend that they see a neurologist and get a neuropsych exam. And a neuropsych exam is testing, is questions, is cognitive testing. It's not scans.
All right. Well, I think we will wrap it up. Thank you again for taking time out of your day to present to the group, Carly.
Of course. Thank you for
Again,
having us.
yes.
I will
Again,
just put my email here in the chat for everybody so you can, in case you need it. Otherwise, all of that info is on that ndbin.org too that I went to if you need anything else from us.
sounds good. Thank you. And those that are still on, please take a few minutes to fill out that survey that will be coming in your email in shortly, either today or tomorrow. We like any and all feedback. Any ideas for new topics is great. And again, be ready for that YouTube video or the YouTube link to come out later this week. So on that note, we will wrap it up and hope everybody has a good rest of the day.